So good afternoon, everybody. Afternoon, evening, morning, depending on where you are. My name is Ashish K. I'm the Dean of the School of Public Health here at Brown University, and really excited to spend some time with all of you with our absolutely fabulous guest today. Seth Berkley is really one of the kind of global leaders who has been so important in this pandemic, but has been working on the kind of critical issues of global public health for many, many years. He is a graduate of Brown, both undergraduate and medical school, has had a very storied career already, has been running Gavi, the Global Alliance on Vaccines, for more than a decade, and then really did an extraordinary job as a co-founder of the Covax facility. Lots for us to talk about on global vaccinations. Before I bring Seth in, let me just say, as we kind of think about where we are in the pandemic, very, very tempting to think we're done with the pandemic. Not only are we not done domestically here in the United States, we're certainly not done globally. We made a lot of progress globally, but there's a lot of important work to be done. And so no one better that I could think of to have this discussion than with Dr. Seth Berkley. So Seth, thank you so much for joining us. I know it's late in the evening in Geneva, but I'm grateful that you're spending some time with us. And I am going to start off because we're here at Brown, and you know and love Brown, and I'd love for you, if you wouldn't mind, just starting us off by tracing your journey. How does a kid who goes to Brown as a college end up running Gavi, and kind of what happens in between, and bring us up to date on kind of what your tenure at Gavi has been like. So let me turn it over to you. And actually, before I do, I'm just getting a prompt. Couple of quick housekeeping things. Sorry, I should have done this first. This is being recorded. If you have questions, put it in the Q&A, and I'm going to sort of drive the conversation with Seth for the first 30 minutes or so, and then I'll start pulling in questions from the Q&A. But it is being recorded, so just FYI. Okay, sorry, over to you, Seth. Thank you.
So thank you so much, Ashish. And I have to say, it's an absolute honor to be with you. And you're right, Brown is very close to my heart. I went to Brown. I grew up in New York City, went to Brown. It opened my eyes to many things. I studied, obviously a lot of science, but I took courses on Africa. I took courses on all kinds of other things. And I got interested in much more of a kind of a global effort. After I left Brown, I decided to do internal medicine. I went to that little city north of Providence, and ended up being at the BI in Brigham. That turned out to be a good place for me, doing internal medicine, but I took some time off and studied in Sri Lanka. There's a funny story behind that, which I won't do now. But and then after I finished that, I struggled with whether to do academic infectious disease or whether to do something, more practical. And what I even though I love clinical medicine, I decided to go to the Centers for Disease Control, ended up in the special pathogens branch, which played out importantly for me. And then I wanted to understand state health, so I went back to Massachusetts and worked, in the Jamaica lab there as kind of a state epidemiologist. And I taught at the Harvard School of Public Health, and I was enjoying that, thinking about what to do. And then Jimmy Carter said, Museveni is in trouble in Uganda. He just came in. There's no health system. Would you go and help rebuild the health system? And I was crazy enough as a young guy to go do that. And I worked on defining HIV and understanding disease there. From Uganda, I moved back to the States. I went to the Rockefeller Foundation, where I ultimately created lots of new programs in their health sciences division, including a number of HIV organizations. The International AIDS Vaccine Initiative helped create Gavi, the Children's Vaccine Initiative, and then eventually moved to Gavi as its CEO in 2011. It was in trouble at that point in terms of financing, and I managed to work on raising finance for it, growing the organization. And, at the end, for those that don't know, Gavi is a very interesting organization. It's a public-private partnership, which the goal is to try to bring those powerful new vaccines to those living in the developing world. We vaccinate more than 50% of the world's children every year. We've introduced 500 new vaccines. and were able to prevent more than 15 million deaths in vaccinating over 900 million additional children. And it was from that platform that ultimately I launched Covax, which I know is what we want to talk about.
I also want to, talk about Gavi as a public-private partnership, and I will go to Covax in a minute. But I think it'd be helpful for our students, but really for everybody listening, to hear a little bit more about how a public-private partnership works, because people have lots of feelings and thoughts when they hear that, and what does that mean exactly, and what's the public part and what's the private part. And so if you don't mind, two things, help kind of us understand how this works. And then second, remind us why you need that partnership. Why can't this just be governments doing it? Why can't it just be WHO doing it? Why do we need a Gavi?
Well, it's interesting. I'll take a step back first to IAVI. And so that issue was about trying to make an AIDS vaccine. And the idea was, let's create a product development partnership that would create products that were specific for the viruses in developing countries. And of course, to do that, you needed industry as well as public center mentality, public sector dollars if you're focusing on the poorest countries. So had some experience doing that. That became a $1 billion effort and really brought new vaccine testing to countries around the world. In a sense, Gavi is a different partnership, but what's critical here, the problem we were trying to solve was the following. These new fabulous vaccines were appearing for pneumonia, for diarrhea, the two largest killers of children, a couple of cancer vaccines, hepatitis B for liver cancer and HPV for cervical cancer. And these vaccines, were being used in wealthy countries. And so the challenge was, how did you get industry to produce them at high volume and low cost rather than low volume and high cost? So you needed industry involved. You needed delivery systems using, the private sector and the tools that exist in the private sector. But you also needed public sector finance. And so we brought together the UN agencies, which are critical in doing this, civil society, research institutions and technical bodies, but also developed country manufacturers, into a working partnership where we could speak to each other, we could work together to solve these problems. And that's exactly what we had to do ultimately for Covax.
Fabulous. That's actually a great segue into Covax. And it's actually a really important reminder that for so many of these kind of complicated problems, like how do we take these fabulous life-saving vaccines and make it accessible to the world's poor and everybody else between the poor and the rich, that the solutions are rarely simple and neat, right? Like they're not like, we just do X. It actually is about bringing together people with very different set of skills, different set of resources, different sets of capabilities. And
can I say my euphemism on that is the following, great problems of the world will not be solved by government. They will not be solved by the private sector. They will not be solved by the academic sector or the civil society sector. What it takes is, as you say, a little bit of all of those pieces in different ways working together. And that is the paradigm that I think is more and more becoming evident for particularly these big global hairy problems, like climate change is going to be another one like that.
Yeah. Great. So I love that. And that actually is a really important teaching point. So let's use that now to talk about the COVID pandemic. So early 2020, virus is spreading. It's in Europe, the United States, and China. It's become very clear it's a global pandemic. You're sitting there at Gavi. Tell me about the thinking that went into how you thought about the role of vaccines in ending this pandemic, how you thought about the issue of global equity, and then how that prompted the creation of Covax. Just walk us through kind of what happened.
So it was actually even earlier than that. So just as a going back, I've been talking a lot about pandemics and the need to prepare for them. And I did a TED Talk. The person who did the TED Talk before me was very famous for that. It was Bill Gates. He did a TED talk on why pandemics are inevitable. I happened to give the next TED talk, which is how you create a vaccine-related program to prepare yourselves for this. And what happened was an organization called CEPI was created, the Coalition for Epidemic Preparedness Innovations. And the leader of that is somebody I was involved with creating that. And we were both in Davos. Now, it was about 3 weeks after the first cases were reported. And this was the moment when the first cases were seen in the U.S. And, President Trump is saying, oh, we got it all under control. There's no problem. And we were sitting at a bar waiting to go to a pandemic session. Actually, the two of us, actually three of us, my wife was with me, and we had a conversation. Is this the big one, or is this a dress rehearsal for the big one? That was number one. And number two is 2009, the previous pandemic of swine flu. Wealthy countries bought up all the vaccine doses, and there were no doses for the developing world. How do you prevent that? So we began right there plotting what ultimately would become Covax. But it was, there were a lot of questions on what to do, how to get the world to come together. The world was fragmenting at that point. There was not a lot of multilateral support. The U.S. is pulling out of WHO at that point. And, and so we're in this weird time, and we decided to go ahead and build this new effort.
So talk to us about the new effort, what the kind of, and I guess as you're talking, because bring everybody up to speed on Covax, what were the tension points? What were the parts that you thought this could go this way and this way? And part of it is it's both the importance of the moment and how you guys captured it and kind of said, this is the moment to act. And then in that context, the decisions you made, I'd love to hear kind of where were the places where you said, well, this could go either way. Let's go down this path and why. So help us understand what Covax is. How do you feel like it's gone? But then also the decisions you made in the creation of it.
So it was, you look back at it as a pretty audacious kind of idea. And the way we thought about it was we needed to kind of put together what the idea would look like. And it was obviously from where we were, public, private, we needed to get people engaged. The first kind of big question, we had no money, we had no, capacity. But how do we think about putting this together? Who do we talk to first? And we began to socialize it among political leaders and began to have a discussion. But one of the questions was, how big should it be? And traditionally, we work, for example, Gavi used to work with 73 poor countries. 15 of those have graduated out of Gavi now, so we work with a smaller number. Should it be the poorest countries only? And our worry was we'd be in exactly the same position, which is people would say, that's great, but we're not going to make any doses available. So we did something kind of crazy and said we should make this a global effort, because the right way to manage a pandemic, if you didn't have any other issues, would be to do it as one world and to kind of prioritize the people who needed the doses, make sure you got as broad a portfolio of vaccines as possible, and then your successful ones you would scale up and get rid of the others. And so we began that process. And just two funny stories about it was, WHO later on said, my God, this is something we got to get, involved with. And they said it shouldn't just be vaccines. It should be broader diagnostics, treatments. And so they created another organization to kind of act as a chapeau over it called Act A, and also created other pillars. But the vaccine pillar was the start of this. And President Macron was the leader who was going to launch this. And I remember thinking, what do I do? And I had my mother's voice in my ear. You're talking to the president of France. Put a tie on. I don't have a tie on today, but so I put on my first suit, my tie. I hadn't done this, in Zoom land for a long time. Of course, I was wearing shorts and bare feet, but and had this conversation, and we decided to launch it as a global partnership. And to our shock, we ended up with 194 countries coming and joining Covax, including, by the way, it's the largest number of countries, since the Paris Climate Accords, and the U.S. wasn't with us at that point, and so it was really interesting. The U.S., Russia, and Cuba were the only kind of outliers. So basically everybody else came in, including China, including Taiwan, including Israel. Just the Palestinian territories. It was everybody came in because they thought we had to work together on the pandemic. Now, the big challenge we had, as I said, we didn't have any money, so we had to raise money. Ultimately, I took Gavi from a $2 billion organization to a $22 billion organization in 1 year. We had the credibility, we had the ability to work on it, but what we wanted to do was began to invest in vaccines. So the Gates Foundation came in and helped us with some upfront finance, and we invested in technology transfers to Indian company. We began a deal with AstraZeneca. We began to negotiate with Pfizer. As money came in, we were able to expand those, but we hit exactly the wall, two walls that were really terrible. One was, the doses were coming in later because the countries had ordered the doses and were hoarding them as we had expected. And the bigger problem turned out to be we were very successful at getting Serum Institute of India to do a tech transfer and to start producing vaccines. They're the largest vaccine producer in the world. We work with them all the time. And 39 days after the first injection occurred in the UK, we did the first injection in a developing country. I mean, nothing like that has ever happened. And we had hundreds of millions of doses behind that. And, we began to move them to, I think we did 30 countries in the next 10 days. And then, so it was really off to a great start. And then Delta hit India. And rather than sharing that technology, both in and out, because we had agreed that 50% of the doses should go to India anyway, but they just full export ban. And we were in the middle of the rollout, and all of a sudden countries were horrified because they had given one dose, they couldn't get a second dose, we couldn't get doses. And so that's really where we were, kind of our legs were cut out from under us. And we asked other manufacturers to accelerate. I mean, Pfizer gave us 1.2 million doses for the world for the first half of 2021. So it wasn't a lot we were going to get there. And so that's when we said, let's think about donations. And we hadn't had donations in the model, but the donations occurred. The G7, agreed to that. And just to bring it to the end to give people an idea of where we are today, we've allocated 1.9 billion doses. We've delivered close to 1.4 billion doses to 144 countries, of which the 1.2 billion of those were for the poorest countries. And today we have, in essence, enough doses to bring the levels up in all of these countries. And one of the challenges is the absorption capacity and where we are. But, it occurred slower than we would have liked, and there were a lot of challenges along the way we had to overcome.
Yeah. Let's talk a bit about, I'm not going to get into the numbers, but the place where the global kind of inequity in vaccines has been most stark has been on the African continent, right? Again, Asia is a big place, and there are pockets of Asia that don't have enough vaccines, but India is pretty well vaccinated now. Still has work to do, and China's got its vaccines, but it certainly has plenty of doses. We can talk about the issues, other issues. But the African continent has been slow to get vaccines, and it's complicated. But large part of it is certainly driven by lack of access to vaccine doses. Certainly had been, I would say. Help us understand why that happened, and kind of where the state of play is today on the African continent. And then I'm going to ask you, you don't have to answer it now, but I'll get to how do we make sure that doesn't happen again? Because it's so striking, Seth. You could look at the global numbers and little pockets here and there, and then there's this entire continent and just striking level of inequity, and with, of course, large costs, so humans and in terms of people's lives, as well as economic and social costs. So help us understand what happened there and what we do better next time.
Well, I mean, the interesting issue here is, when the Indian export ban occurred, we had a deal with AZ, AstraZeneca, parent company, and that was for all of the wealthier countries who wanted it and the wealthier developing countries. And then there was the Serum Institute of India contract for all the developing countries, included Africa. And as I said, you said India's done well. They've had 1.5 billion doses, of which all were doses that were doses that we had tech transferred to Serum. Half of those doses were for Africa. And since Africa got none of those, we eventually were able to move some of the doses from the other manufacturer. And of course, when new manufacturers came on, we were able to do that. But that really was the main reason why there weren't doses done immediately there, and was the problem. Now, not every country in Africa has done as you know, they have different levels of response. And today we had, in January, we had 34 countries that still had less than 10% coverage. And, you know, most of those, or a large number of those, were in Africa. By today, that's down to 19 countries. So we're making progress lifting up coverage. And the AMC countries have a coverage now of 40%. And so it isn't, you know, 64% is the global total. And, you know, so it isn't, there are inequities, but the real inequities are in the low income countries. And the challenge there is the you know, the health systems that are you know, somewhat, they're not resilient, they don't have good health manpower, and so they, by the way, deliver vaccines all the time. And I always want to make this point because
I was going to ask you about that, because it's not like these countries are unable to deliver vaccines. In fact, they do it all the time, right? So
exactly, and when, in fact, when reporters would ask me that, they would imply that, you know, well, they couldn't do this. Not true at all. I mean, and in fact, when I was asked, you know, about the relative capabilities, I said, actually, countries, you know, have a better capability to deliver vaccines than we do in the United States or in somewhere else, because they routinely do campaigns and have the skill set. The difference is those campaigns are planned way ahead of time, and they're planned with stable doses of products. I mean, we have outbreaks, obviously, and do it in a scramble, but we often do coverage in well-planned campaigns, and this wasn't that. So, you know, that was one of the challenges that occurred, and there were many other challenges that came with this particular disease because of the politicization of the vaccine and the whole vaccine approach. Also issues, some of the vaccines, for example, Pfizer is a minus 80 degree, even though we've built cold chain across Africa, not ultra cold chain. We had to build new ultra cold chain and put in, you know, for 54 countries, you know, the ultra cold chain capabilities, you know, et cetera, et cetera. So many problems, but you know, one of the challenges, I mean, if I look at a country like DRC, very low coverage now, hasn't been a lot of uptake. They didn't want the AstraZeneca vaccine because Germany at one point stopped it, and so did France, and said it didn't work in the elderly. It turned out it did. They just didn't have the data. But, you know, once the country said this is not a good vaccine, we don't want it, and yet at the same time we're doing yellow fever, whole age campaigns for the country, getting reasonable coverage, 60 to 70%. So this is the kind of craziness of the situation. And, you know, in mid 2021, there was enormous demand, and I think we could have gotten very quickly high coverage. But now people turn the telly on and they see everybody's taking their masks off, everybody's going back to normal, you know, and I think that's a problem because the virus, you know, we're done with the virus, but the virus isn't done with us. And I think, to your point, you know, this is the complacency now is a real risk around the world. And, you know, I mean, India had it before Delta. You remember they were, yeah, we're doing a good job. You know, we can export vaccines. It's good, you know. And of course, then that, you know, that horrible Delta wave hit, and then we had Omicron. What is Pi, Rho, Sigma, Tau going to bring us? And so the challenge for us is to make sure that every country at least has their high-risk populations vaccinated and boosted if timing-wise they need that, and we're not there yet.
Yeah. Two quick things. One is in end of January, early February of 2021, so a little over a year ago, I was asked to give a talk, a big event on Zoom, about how India beat COVID. And I said, when they asked me to give that talk, I said, I don't know how to give that talk. I don't think India has beaten COVID. And the organizers were like, no, India beat COVID. So I went in and I said, here are the 6 theories of how India beat COVID, and let me explain why they're all wrong. And at the end, I said, I don't have an explanation for why India is doing as well. I hope it continues to do well. I hope one of these things turns out to be true, but I am deeply worried that India has not beaten COVID. And then 3 weeks later, you could start seeing that early uptick of the Delta wave that, of course, ended up being so catastrophically horrible for the Indian people. So really, really interesting. I'm going to, even though we're still in the first half hour, one of the questions that's been asked that I'm just going to kind of get to because it's pertinent now is, you know, If one part of the strategy is thinking about future variants, none of us quite saw Omicron coming, and at least the way it showed up, we don't know what the next variant is. If part of the strategy is let's get every high-risk individual vaccinated and boosted, two related questions: how far away are we from being able to do that, and what are the major barriers to accomplishing that goal?
Yeah, so first of all, I mean, the honest answer is we don't totally know. But if I break it down, healthcare workers, we think we're around 75, 76% coverage. That's a broad definition of healthcare workers. Not as good as it should be. We'd like it close to 100%. And of course, that doesn't include what we would call today effective coverage, which would include boosters. That's primary vaccine, 2 doses. Elderly, much worse, like 36% or something like that. And what's interesting about that is, we don't really have easy access points for getting to elderly in developing countries. And, they don't get other vaccines. It's not like here where you give them, vaccines against shingles or pneumonia or other things, or flu vaccines on an annual basis. You don't do that. And so it's part of a new paradigm, and you really have to socially mobilize to do that. But the third group that's critical, and it has to do with the variant question, is the immunosuppressed and the people who have opportunistic infections and are at risk of disease. And that group, there's also the issue of confidentiality, and in Africa, for example, a lot of that's HIV infected populations, and you want to prevent variants, make sure everybody's on treatment, and also make sure everybody's vaccinated. Even if the vaccine doesn't take, give a booster, or even a second booster, and so that's really where we have to go. And the challenge now is really refreshing that view, because we originally came out with what we thought was a pretty bold idea. We said, vaccinate 20% of the world's population at the same time. Every country should do that. They're elderly, they're healthcare workers, and they're people with, risk factors. And of course, the challenge with that was, Japan has 32% of people above, that. So some countries would have to be substantially higher numbers. But, and that's not what happened. What happened was, countries wanted to protect their populations. They wanted to vaccinate all of their populations, all of their low-risk populations. And so we ended up not getting, that prioritized in developing countries, nor did we get the vaccines early on to do that. And I think that's an important lesson going forward, because frankly, this is a disease that isn't, it has a significant mortality rate, but it's not a, incredibly high mortality rate. And, what happens next time with the next, evolutionarily, naturally occurring pandemic, we're certainly going to see it. So, how do we change that mindset? I think that's a real challenge for us going forward.
Yeah, that's a really important point. So let me ask you this. This sort of builds on the question of what we saw with serum, India, the Delta wave, and then, it's true. I did say, India's done relatively well, but you're right. Half of those vaccine doses would have gone to the African continent if India had not put in an export ban. But assuming that countries won't put in export bans, or that won't fall to vaccine nationalism, probably not a good assumption. There's no reason to think that a future pandemic countries will be more globally minded. I mean, we can hope for it and wish for it. So, I'll bring up a specific example. I was talking to a colleague, a senior colleague at the African Union, about 9 months ago or so. And he said, this is the last pandemic where Africa is going to turn its destiny over to others. We have to build our own capacity to manage future pandemics. I think a powerful and important set of ideas there. How do you see us managing a world where, as much as you and I may say nationalism, this kind of stuff is not constructive and helpful for the world, we've got to live with the reality that is going to be a response or a reaction to many countries. How should we ensure that there is plenty of capacity and plenty of vaccines or other therapeutics really in every part of the world, so no one set of countries is dependent on another?
Yeah, well, I mean, that's a complicated question, because first of all, we need more capacity. So just to give a sense, when Gavi started in 2000, We had 5 suppliers. 4 of the 5 were in wealthy countries. Today, we have 17 suppliers. 11 of the 17 are in developing countries,
That's
and
progress.
including a supplier on the African continent.
Yep.
But relatively, Africa has less suppliers. And one of the challenges, though, is even when you move to a continent-wide view, you still have to worry about the nationalism issues because, of course, there are 56 countries on the African continent,
Exactly.
and you have to make sure that they would also be shared and dealt with and where we are. But I think there is no question that expanding that number. Now, the challenge is you don't want 250 manufacturers. So maybe you go from 17 to 25, but there is an economy of scale. The reason Serum did so well is they had the teams, the space, the reactors, the supply chains, and so they were able to pivot and produce massive quantities of
Yep.
vaccine. That's what you want. Ideally, by the way, you want that in Singapore and Rwanda, few places where you could saturate the whole population with an engineering run. And so, the challenge then is going to be how to do it. And the most important discussion on this, which hasn't happened so much, but is critical, is you need a sustainable business model. Because if in peacetime you don't have anything to do, it's going to lose its interest. Just to tell you a story about this, when during the Ebola outbreak, there was a question, vaccines came up and, we were able to go ahead and get a vaccine proven to work. The challenge was who's going to produce it. And so we stepped up. We didn't have the money. We put out an advanced purchase commitment, $300 million. We'll buy vaccine. We had to go and everybody said, Seth, no problem. Money, no problem. Whatever it takes. This is the epidemic of the century. Well, 3 months later, when I went to get money, everybody was like, Ebola? That's yesterday's problem. It's not something we need to do. So one of the challenges in peacetime, how do you support these facilities? And that's about having a diversified portfolio of vaccines that people want, maybe some global, maybe some regional, and then some excess capacity so you can expand it. And you have to have that conversation because this is expensive to get a manufacturing facility. It's expensive to keep the staff because they're very valuable. They can move anywhere in the world and do that. And so what we have to do is make sure that it's well thought through how that is done. The technology to do it is easy, and there's now new technology that we can talk about that changes some of the dynamics for that. But it's going to be about making sure we don't create white elephants during this period where we build a lot of plants that don't have a real plan for how they'll stay and move that forward. And of course, we'll help because we are the largest purchaser of vaccines in the world. We'll buy, but we can't buy at 20 times the price. You'll have to figure out how those facilities, when they're young, get subsidized so that they can be somewhat competitive. We have some flexibility, but our long-term goal is to make these products affordable for countries so they can pay for them with their resources. So that's kind of where we are on those issues.
I love that. It's a very complicated set of issues, but I think figuring out the peacetime strategy around this is critical. I'm going to come back to asking some questions about the future. I want to get to one question from one of our colleagues who asked, according to the Africa CDC, the primary challenge for vaccinating the continent is no longer supply shortages, but rather logistics, delivery, vaccine hesitancy, as some of the stuff you talked about. How is Covax shifting strategies to get more shots in arms? And what more, and here's a really critical question, what more can the US and other high-income countries do to support the last mile vaccination strategies of low and middle income countries? So a bunch of related good questions. Thoughts about what Covax is doing and what should the U.S. government and others be doing?
So we focused initially on the supply because that was where the real problem was. But at the same time, we were continuing to work with countries to begin to prepare. And we said to countries, prepare, the doses are coming, prepare, the doses are coming. But, governments are busy, they're doing other things. A lot of them didn't really pay it. Some did.
Right.
I mean,
Right.
and Rwanda has coverage now. I think it's 70% and going up, and so some people took it seriously. Others, were kind of shocked when all of a sudden the doses came. But the point is that what we had to do then is even do a more hard pivot. And so we've created a new COVID vaccine delivery partnership, bringing together all the partners on the delivery side, working with the AU, working with the World Bank, working with UNICEF, WHO, civil society. And the goal of that is to take those 34 countries that were less than 10% and pick off a bunch of them and start creating bespoke plans in each one of those countries. In the first 10, we're pulled off and the visits are going and they're beginning to do that. And then to provide whatever it takes to lift the barriers that they have, whether it's hesitancy, whether it's a supply chain issue or a staffing issue or a cash issue for moving forward. And so that's what we're doing. Now, we are in the midst of a fundraising effort to support that because we've used all the money we had before to get to where we are today.
Yeah.
And the U.S., as some people may know, had a COVID supplemental in the bill that just got passed, but that got pulled out at the last minute, the whole thing. And that included not just vaccines, included diagnostics and treatments because of some political issues associated with it. They've tried to put that back in as a standalone bill, but it's gotten stopped in the Senate. And so, the U.S. has an important role to contribute. President Biden will host another COVID summit, and the lead thing of that summit is vaccinate the world, and we're the instrument to do that. But we're going to need more money for delivery, particularly for ancillaries, for dose donations. And then lastly, we're asking for something unusual. We want to create a pandemic vaccine pool. And the idea of that is not to buy more doses now because we have doses, but we don't know what the next variant is. Will we need a new variant vaccine? Will we need pediatric doses? Will we need a particular vaccines working better with the next dose than others? And so what we want is a flexible pot of money where we can get in the front of the queue rather than the back of the queue for countries going forward. And so that's what the U.S. can do, is both contribute to that, but also help lead. We'll be having Germany as head of the G7 will be hosting the event for us on April 8th, where we hope to bring a group of countries together to do this financing of about $5.2 billion.
No, that's great. It's really great. I want to, something that was brought up, and I want to kind of get to this issue of vaccine confidence and vaccine hesitancy. My sense, and I want to know if you agree with this, is pretty complicated issue, not so straightforward. There's a bit of a narrative taking hold in the U.S. that, the problem is people are just hesitant, they don't want to get vaccinated, and that's why it's unsolvable. I think to say that that's simplistic would in fact probably be an understatement.
Yes.
It actually, I think there are elements of it that are just downright obnoxious or even racist, part of that, but we won't go there. But there's a sense, right? Like you've heard these narratives. Help us understand, since you have so much of a better feel for what's happening on the ground in many of these countries, help us better understand what is fueling the lack of confidence. Where are those barriers? I don't mean supply chain and logistical, but really on the human side, on the demand side. And what do we do? How do we address it? How do we help address it?
First of all, some history. I mean, so if you had asked me this a couple of years ago, I would pull the study out and I would say, actually, statistically, the lowest level of vaccine confidence in the world is in France, Louis Pasteur's country, and the highest level is actually in Rwanda. And in general, developing countries actually, are do better on the vaccine confidence side because they see the diseases. Nobody wants their family members to die or their kids to be disabled, and so they see the diseases. Whereas in the West, of course, the vaccines are so good that people have forgotten about these diseases, how horrible they are, and it's much easier to say, gee, maybe there's some side effects, or it has some chemical I don't like, or it's GMO, or whatever the arguments are. So in general, developing countries do better. But this time it was bizarre. So first of all, you're right in terms of problems, and our colleagues, John and Gengasan at the AU says this all the time. To talk about vaccine hesitancy when our coverage rates are 10%, that's not the problem. If we get to 60 or 70%, there'll be some people who are, don't want to get it. And let's not forget that the U.S. is stuck now in the mid 60s and can't get beyond that. So the idea of a 70% goal for the U.S. doesn't work. But what's interesting is what we saw that was shocking to me was because it was so politicized at the beginning, people were watching. It's one social media echo chamber, and they were watching, Bill Gates is really injecting, people with chips so he can track them. These vaccines are making reproductive health, or, doing things politically to people. Or, I mean, there were just so many crazy theories running around, but they had really deep roots. And and as that skepticism spread around the world, it gets inflamed in countries. And as you know, that skepticism was not only politically motivated, but then, it was amplified by countries who wanted to use it as a way to divide groups. And that's a really interesting thing, because vaccine confidence is something that you can use to undermine democracies as a way, because you kind of undermine the beliefs in science, which are so critical to what we do. So we are now seeing a lot of that type of vaccine hesitancy. So surprising, we're seeing health workers sometimes who don't want to get vaccinated. And it seems crazy. Now, the traditional tools we always do is to go back to the communities. It's the religious leader, it's the village chiefs, it's the local political leaders, et cetera. And, arming them with the facts moves us forward. But, in general, people point to that as a problem. It's more of a problem in the West that now has rolled into the South, rather than, a problem necessarily that's there.
Yeah. Yeah. A colleague of mine in South Africa said, it was interesting. I think it was soon after Omicron was identified first in South Africa. We were talking about lack of vaccine coverage in South Africa and what the issues are. And he said, my problem with America is not what you don't export, the vaccines, but what you do export, the vaccine misinformation nonsense. And he particularly called out Tucker Carlson as like somebody, I didn't know this, very popular under certain social circles, in social media circles of South Africa. And I was like, oh my God. I mean, I thought Tucker Carlson was a challenge for us in the United States, but the guy sort of, so these are, as you said, it's a global media ecosystem. And this stuff travels and resonates really quite broadly.
And we've been working with the media companies, not with Tucker Carlson, but with the Googles, with the Facebooks, or now it's Meta, and Twitter and others, to really help people. Because here's the problem in general with vaccines. So you have a small group of people, call them 5 or 10%. They will not get vaccinated no matter what, right? They're set in their ways. And then there's 5 or 10% who they'll do anything. They'll march 100 miles to get vaccines. They'll sleep overnight. And then in the middle are all these people who can flip either way. And the real challenge is those are the people you're really trying to work with. And so what the critical thing there is that when they have a real concern, we heard that mRNA vaccines were made too quickly and, nobody's had any safety work on them. They then go, where do they go? They go to, Dr. Google and try to get that information. What we worked with is to make sure that if you're really asking a question like that, you get to an authoritarian source, not to, some crazy site that, kind of has these conspiracy theories in it. And it's really trying to meet the needs of people and help them be educated, in addition to all the other things that we have to do. We of course have the president get vaccinated. We have the ministers, the cabinet, the first lady, and the religious leaders all doing that in a public way to kind of build confidence in the populations.
Yeah. Great. I want to talk about mRNA vaccines since you mentioned them. There has been, I think, one of the more problematic messaging. This is not born out of misinformation. That's a whole different thing. But there has been, I think, a real challenging messaging that somehow the gold standard of vaccines is mRNA vaccines. And I even hate saying that because it somehow reinforces this. My personal view, and I've said this publicly many, many times, is that's just not true.
Well, we don't know. It's more we don't know. But let you finish your question. So
no, but I would say that, but to the extent that we do know, and again, to the extent that there are data out there, there's plenty of data there that several of the vaccine platforms over the long run probably produce as durable a set of responses. Look, if your goal is to produce the highest level of antibodies in the first 7 or 14 days, maybe mRNA is the right way to go. But that shouldn't be the goal. This should be about durable immune protection over the long run with T cells and B cells and everything else. And in that context, I think there's plenty of reasons to believe that there are other platforms that are probably as good. First of all, do you agree with that? Second is, how do we get away from this narrative that has started forming that there are good vaccines and that there are kind of the rest. Whereas I actually think we are in a blessed moment of a large number of very, very good vaccines, with the differences are far less important than we think. First of all, do you agree with that? And what do we do about that?
Well, first of all, I do agree, and with one exception.
Okay.
What mRNA can do that no other product can do is the speed.
Yeah.
So, they published the genome. The Chinese published the genome of this agent. You can have any argument one about what happened in China, but it got published quickly. Thank goodness it was a lab that could do that. And, 39 days later, there was a vaccine in a vial. 63 days later, that was injected. And even that can be sped up. You can't do that with any other technology. So
Yep.
where mRNA is the best is, if you have to move quickly and get a product to start with. But then, there's two sides to it. One is the side you talked about. There are other vaccines that, either as the series may be better, or heterologous, vaccination may give more durable protection and give broader protection as well, because it's training the immune system in slightly different ways. And so we've seen that now in some studies. Now, what's interesting is economically very hard, because companies don't have any incentives to do studies to say, gee, if you give a dose of mine and you give 2 doses of our competitor, that's a better vaccine. So CEPI has been doing a bunch of those, but they're small scale. But I want to make a bigger point, and this is a real problem. And by the way, there was an article in the New York Times today about all the problems in Africa, vaccines. We see a lot of those. But that article started out saying, and they said to me, they called me up and said, it is unethical for you to use any vaccine other than mRNA vaccines, because that's the gold standard. That was the original hypothesis of the article. And I said, that's completely wrong. So the interesting thing now is, we're in a situation where people are thinking like that the best vaccine is a high efficacy vaccine, not a bad vaccine, but a high efficacy vaccine that you can use. So I'll give you an example. Recently, we have a new vaccine that got approved, Novavax. It is an adjuvanted protein. It is stable, very stable. It can be in a regular refrigerator. It has a long half-life. It has a good reactogenicity profile, and it's cheap. So here's this vaccine that is perfect for what you might want to use in a rural area, without good infrastructure. We're trying to deliver Pfizer. It's a good vaccine. Requires minus 80 degrees storage capabilities. When you take it out, it's not stable for a long period of time. It needs special immunization, special vaccines, special syringes of a different size than the standard. It needs a diluent that has to be done separately, et cetera, et cetera. And that vaccine is not good for southern Sudan, where you don't have the capabilities to do that. And so one of the challenges right now, and this breaks my heart, is that Novavax, there's no demand for it. Because people are like, it came late, we don't know it, and all we hear about are the mRNA vaccines. And so one of the challenges, without being an advertiser for other vaccines, we have to make sure countries know that they need a portfolio, a small portfolio, not a big one. Maybe they use the mRNA vaccine in their capital city and their academic medical center. Maybe they use a J&J as a single dose, even though it's now a 2-dose, but they can use that in an area that is, fragile and in an emergency setting, because you can give it in a campaign, and then you use a more stable vaccine like, an AZ or a Novavax in the rural areas. And the idea that, one is better than the other, in fact, it is the vaccine that is right vaccine, right place, right time.
Yep. Great. Fabulous. All right. I'm seeing more questions, and I have one more big question I want to get to with you that I've been dying to ask, which is, okay, so we still have a ways to go with this pandemic. We're not done. There's all this new work being done on a new generation of vaccines, intranasal vaccines, polyvalent vaccines against coronaviruses. Fast forward 5 years. Let's say this pandemic is largely in the rearview mirror. Things have calmed down. The world is largely has a good immunity profile. One can't help but think that one of the few silver linings of what has been an otherwise pretty horrible pandemic is that it ushers in kind of an almost a golden era of vaccines, that the amount of investments in new vaccine platforms and new vaccine technologies, the speed, et cetera. And I wonder if this is a moment to be optimistic about vaccinating against a series of diseases where the investments have been really just inadequate, despite all of your efforts, despite the efforts of the Global Fund and others. It's like you try to get the world, it just would, the focus has not been there for a whole series of diseases. I wonder if that changes. Are you optimistic, hopeful, think we could really do this stuff differently? And maybe let me ask one other question. I'm going on too long, but part of preparing for future pandemics is addressing the ones that we have right now and building the infrastructure to address those. I don't know that we need to have excess capacity. We have plenty of problems to solve. Anyway, I'd love your thoughts on kind of that set of issues.
Well, I mean, you couldn't do what I did if you're not an optimist. I mean, let's start there. But I mean, I spent 15 years trying to make the world focus on AIDS vaccines for developing countries. And what's interesting is that technology moved really slow. It's hard. It's really hard science. I mean, I suppose it's possible science will never solve it. But one of the big, breakthroughs we made was finding broadly neutralizing antibodies that humans were making that could neutralize all the strains. Now, the challenge is we didn't know how to make people make those strains, and it turns out that you get post-translation modification of the antibodies, and so it's complicated science. But what's really interesting is stuff that I started 12 years ago that people were still moving along. All of a sudden, they're now doing trials with mRNA vaccines because they can turn them around so quickly, with the idea of using multiple vaccines to try to drive this type of immune response. So I even think for some of the most complicated things, these breakthroughs are really going to make a difference. And I don't think we're going to tolerate the normal 7 to 10 year timelines for vaccines now. So, there are big diseases. I mean, TB is probably the biggest, in terms of infectious disease killer. I mean, COVID's higher now because of the pandemic, but,
right.
And we have terrible drug resistance for TB. There's some breakthroughs that have occurred, but, can we now put that on steroids? We have our first malaria vaccine. It's not great, 39%, efficacy rate, but given how common it is for
still going to make a big difference, right?
Well, for every 200 children you immunize, you save a life. So it's a good vaccine given how common, malaria is. But now we can, perhaps use new technologies, and already people are talking about that. And just to say, the Moderna announcement that just occurred, and I know you've interviewed, Moderna here before, they've decided to build a plant that is not about COVID in Kenya. The purpose of that plant is to work on all these other vaccines. And, I visited Moderna before there was a COVID, a program, because I was interested in their ability to work on some of these tropical diseases that otherwise, because the bigger problem you had with the tropical diseases is if you're trying to solve Lassa fever, it's a small problem. It's a terrible problem, but it's not a big disease. There's not a big market. You don't need massive amounts. So how do you produce a vaccine for that and have the investment be limited and the production be such that you can do it modularly, in small amounts? And if we can begin to solve those problems, we all of a sudden have the ability to work on these types of diseases and change the world. And frankly, I'm interested in cancer vaccines. I think many of our chronic diseases are going to turn out to be infectious in nature. And, if we have the tools to be able to experiment with it and make vaccines quickly to try it, to your point, maybe mRNA is not the long-term vaccine, but it might be the way to, to do 10 trials and, within a year to move something forward, because you can do that in a way, whereas normally it takes us 3 years to 4 years to do trials, make the vaccine, et cetera.
Yeah. And I believe mRNA vaccines do have lots of durability. And again, as I said, I just think from a durability point of view, there are other vaccine platforms that are probably pretty competitive. I agree with you that you can't build them up fast enough. Thinking particularly about something like the J&J vaccine, where my sense is after a couple of doses, you've got a pretty high degree of protection.
I mean, the challenge with J&J, which may turn out to be important, we actually paid at IAVI for that platform. So it's interesting. So we did it for HIV, didn't work for HIV. The TB people paid for TB, didn't work for TB. Then they used it for Ebola, and it showed, protection, and now it's being used, obviously, and it shows protection here. So I know that platform well. The challenge is that if you're using a vector and you keep using a vector, you may get anti-vector immunity. Now, we've seen it able to overcome with a couple of doses, but it's probably not the vaccine you want if you need to have an annual booster, wwhereas some of the other technologies don't have any anti-vector immunity, and therefore, if you have to have annual boosters or high risk boosters, you can use them. So I think these are the things we can learn about and improve upon as we make better vaccines. And by the way, yellow fever is one that also needs a refreshing. And polio just got refreshed with the novel OPV, and that's an important. So there's lots of things that will have to happen here.
Yeah. Let's come back to Gavi. As this pandemic, and again, we're not done, and we've got lots of ways to go, but as this pandemic eventually calms down and gets into where do you see the future of Gavi? It's played such a large role in this pandemic. I can imagine all sorts of ways in which Gavi will be changed by this pandemic. Not asking you to prognosticate with any high degree of certainty, because I'm sure there's a lot of issues, but what do you think? I would think, okay, I'll tell you my thought, and is the future of Gavi and its need is as bright as ever. And people, I think, will understand that in a way that they've understood, but even more so. Are you pretty optimistic that people are going to continue to make these kinds of investments and making sure that the technology gains that we're getting from vaccines will continue to be available for all of humanity and not just a few?
So the interesting issue is, up until now, we've seen a year-on-year increase in economic growth across the world. I'm not saying there are countries that are lagging behind, but we've seen hunger go down with vaccination and improved water and sanitation. We've seen death rates go down, and as a result of that, we're seeing economies grow. And so I mentioned, I think already, that we've had a number of countries that graduated out of Gavi, and they're continuing to pay for their vaccines, because now the vaccines are cheaper because of the market shaping work. So we actually asked the question, should Gavi go out of business? And it turns out there's a lot of countries who still will remain economically lagging, and we have a history for that. But then the question is how do we deal with new vaccines? How do we deal with epidemic vaccines? We keep the global stockpiles for Ebola, yellow fever, meningitis, cholera, and so, I see us in a way playing a role of market maker, bringing innovations to wide-scale use and distribution, keeping warm all of these lessons we learned. I mean, it was shocking when we set up Covax how many things hadn't been thought through. Simple things like, how do you label a vaccine in a pandemic? You don't want to do it in the local language because you want flexibility to move them around. Do you put an expiration date on it, given the fact that the shelf lives initially are short because you don't know how long they're going to, many issues, the no-fault compensation, indemnification, liability. So we want to keep all of those alive. And so that's the way we're thinking about it. The challenge we have now, and you know this well because you're in these conversations, is there's a lot of organizations who want to own pandemics. And one of the challenges is we're too busy fighting this pandemic to be spending our time lobbying and writing papers on theoretical things. And so the Global Fund and us are both really trying to continue to implement and hoping that people will say we have to learn the lessons from the people who really did it and not just from the people who are talking about it.
That as things calm down, whenever that is, and as we begin to draw the lessons and think about who do we want leading that effort towards better preparedness, it's got to be the people who actually did the hard work on the ground. You're absolutely right. The number of people who I have discovered are pandemic experts who, 2 years ago, and 3 years ago, when we were all talking about these things before this one, that we'd never heard of them. I think my hope is that'll get separated out over time, because it is Gavi and others, but I do want to just say, particularly Gavi, who stepped up. You have stepped up with Covax. And Seth, I don't mean to overstate this, but I don't think I am. The work you and Gavi have done not only have saved millions of lives of kids before this pandemic, but millions of lives of people during this pandemic. And it's hard to understate the kind of value of that. So thank you for your leadership over the last 2 years. We're not done, but let's keep going. And thank you for taking time. I know you have an extraordinarily busy schedule. Thank you for taking time to spend with us today and this evening, talking through these issues. I learned a lot, and I'm just grateful for your leadership and for everything you've done. Thank you.
And thank you for having me, and thank you for Brown launching, like the sailboat behind me, launching me on my career. I actually taught at Brown afterwards when I was still living in the States, and it's an amazing institution, and really love it. So
we'll come back and visit and teach, and we have a lot to learn from you. Thank you very much. Have a great evening. Bye-bye, everybody. Bye-bye.